just go ahead and get started and everyone will join in when they're ready. Oh, thanks, JP. Well, welcome everyone to our first inaugural early career immunology webinar for this year cycle. We tonight is our first case/interesting topic webinar, and they will be monthly from here on out. So after this webinar, keep an eye out for emails regarding the next webinar, which will be on October 7th. But tonight we have a really special webinar organized for you where one of my colleagues, Jasmine Atala, who is a second year fellow, allergy and immunology fellow at CHOP with me, is planning to present a case that we've titled A Therapeutic Dilemma, Bone Marrow Transplant or Thymic Transplant in a Patient with Skeletal Dysplasia and Immunodeficiency. And then we have some really exciting guests who are also joined us to talk more about the science behind this condition that we diagnosed in our patient. And so we have Doctors Gigi Notarangelo, who is an NIH Distinguished Investigator, and Dr. Marita Bosticaro, who has also joined us from Dr. Notarangelo's lab at the NIH. So, Jasmine, whenever you are ready, you can go ahead and start presenting the case. And I just wanted to remind everyone the chat is active, and we love audience participation. So, with differential diagnoses, feel free to ask any questions and interrupt us, and I'll prompt Jasmine with anything. I'm looking forward to a fun discussion.
Awesome. Thank you so much, Whitney. So yeah, as Whitney said, this is a really interesting case and really presented a therapeutic dilemma for us in order to discuss, bone marrow transplant or thymic transplant in our patient. So I'll go ahead and start. So this patient came to us as a 2-month-old female born in Qatar with a history of low birth weight and multiple congenital anomalies, including skeletal dysplasia, which included hip dysplasia, calcaneovalgus deformity, also had craniosynostosis, multicystic kidney disease, hypotonia, also had feeding and swallowing dysfunction with gastric tube dependence, and also congenital hypothyroidism, congenital heart disease consisting of a PFO and a hypoplastic aortic root, also retrognathia and nasal septal deviation. And our immunology team was consulted due to pertinent genetic findings that were done in Qatar. Other really pertinent history is she had no infectious history, no history of any rashes, and family history was pertinent for consanguinity. So mom and dad are first cousins. No family history of known immune defects or early unexplained deaths. And she does have 4 other siblings at home who are all healthy. So we obtained labs at 2 months old when she came to us. Looking at the CBC on the left, reassuringly, she had a normal white count and reassuringly had a normal absolute lymphocyte count at 3,000. However, when we did the flow on her lymphocyte panel, pertinent findings showed a CD3 absolute count of 21 total T cells, with 0 being CD4 and 3 present of CD8 cells. But she had normal B cells and normal NK cells. And then we did do mitogen testing, so her PHA was markedly reduced compared to the control, so less than 1% of the control. And so these labs were consistent with a T negative, B positive, NK positive SCID. So any differential diagnoses that anyone can think of?
Help us out and shout out in the chat if you have. Oh, nice. Yep. Schmenke's, I honestly have trouble pronouncing it as well. Oh, EXTL3 deficiency.
Awesome.
Great.
Yeah, very good differentials. So these were the differentials we thought of as well. So cartilage hair hypoplasia, Schimke, osseous dysplasia, MYSM1 deficiency, MOPD1 deficiency, or Rothman syndrome, and then also EXTL3 deficiency, which is immunoskeletal dysplasia with neurodevelopmental abnormalities, which actually is what our patient ended up having on genetic findings. So she actually had homozygosity for EXTL3, so inherited one copy from each parent. And upon further review, EXTL3 was found to be an enzyme that regulates biosynthesis of heparan sulfate and is important for skeletal development and hematopoiesis. It also appears that it could be important for hematopoietic intrinsic T cell lymphopoiesis and thymic epithelial function, which is how we got connected to Dr. Notarangelo, Dr. Bastacardo, and the NIH to help do the thymic organoid study for our patient. Also, through literature review, we found that her specific variant was similar to a homozygous variant that has been previously reported in two members of the same family with skeletal dysplasia who did have a T negative, B positive, NK positive SCID phenotype. And they did develop Omen syndrome features, and unfortunately, both passed without a hematopoietic stem cell transplant at ages 6 and 10 months. Looking more closely at her variant, she had a missense variant, which was located right outside the glycotransferase domain. She had a very high CAT score, above 25, and a very low allele frequency in NOMAD. She also, in NOMAD, there were no homozygotes reported. So, taking this all into account in her clinical picture and the history of consanguinity in the family, it does fit the disease, her clinical picture does fit the disease phenotype. This is the thymic organoid study that we sent to the NIH to have done in their lab. And this shows, looking at the bottom in comparison to the control, that our patient's CD34 positive T cells were able to differentiate into mature T cells when placed in this thymic organoid, which indicates that there could be a problem with a thymic problem rather than a T cell hematopoietic stem cell maturing into cells. So rather than it being a lymphopoiesis problem, more so considering a thymic problem. And so this brings us to our dilemma and our question of how should we treat our patient? Should we do a hematopoietic stem cell transplant or should we do a thymic transplant?
Thanks, Jasmine. Amazing job. So we thought at this point, before we tell the remainder of our patient story, that we could invite Dr. Gigi Notarangelo to tell us a bit more about this condition, and also Dr. Bastacardo to tell us about all the research that they've been doing.
Thank you, Whitney. Thank you, Jasmine, and thank you for inviting me here. So I'm going to share my screen. Okay, do you see it?
Yes. Yep.
So I'm going to discuss a little bit the pathophysiology and the natural history of XCL3 deficiency. Let me start by saying that actually you correctly hypothesized as an alternative diagnosis Schimke disease. There are, a few other immunoosseous dysplasias. Perhaps the most common one is actually cartilage hypoplasia, but you should also remember that PGM3 deficiency also includes skeletal dysplasia as well as neurological issues, and it's quite variable. In the clinical presentation, of course, for Schimke disease, what is really important is the renal involvement, which often represents a major risk factor for outcome. Cartilage hypoplasia is extremely variable in its immunological phenotype. Some patients present actually a SCID phenotype, but many others actually do not and have very mild immunological manifestations, and even a skeletal manifestation of cartilage hypoplasia may or may not be present. So it's quite variable. Just keep that in mind. So what's the natural history of EXCL3 deficiency? First of all, it's hard to actually make a strong case because the total number of patients out, and you should add actually the patient that Whitney presented and Jasmine presented, but the other patients that have been reported in the literature make up a total of 20 patients, so not that many. However, the skeletal phenotypes is, I would say, rather consistent. Platyspondyly is very, very common, brachydactyly, short stature, short limbs, kyphoscoliosis. A very important aspect is also the craniocervical stenosis. Many of these patients actually did require neurosurgery early in life. Hip anomalies are also frequent, and we show a few examples of that. And then from a neurological standpoint, the patient that actually Jasmine presented had hypotonia, and particularly axial hypotonia has been reported in 50% of the patients. There is a global developmental delay also frequently seen. Motor developmental delay is also possible, and then seizures, joint contractures, hypertonia has also been reported. These patients often have facial dysmorphisms of various kinds. And another thing that actually I don't think the patient that Jasmine reported had evident, but has been reported in several other cases, is the presence of cysts, some of which actually can be diagnosed prenatally, especially liver cysts are more common than renal cysts. And finally, from an immunological standpoint, T-cell lymphopenia is quite frequent, not always present because, as pointed out, actually some patients don't have T-cell lymphopenia and end up developing actually an Omen phenotype, where T cells may even be present in higher than normal number. Hypogammaglobulinemia has been reported only in 3 patients, although it has not been studied in all cases. It's very difficult to say what exactly is the outcome of these patients because most of the cases have been reported when they were still alive, but we don't know how many of them eventually survived. So there are 5 cases that have been reported to be deceased in the literature. And likewise, in terms of treatment, there is very little that has been reported in the literature. 3 patients have received hematopoietic stem cell transplantation. All 3 are alive with very good engraftment. There was 1 patient for which a thymic tissue implantation was considered and was still pending. So again, I think we still need to make a stronger case of what is the outcome of these patients following transplant, which I think at this point represents the most logical option. So these are actually the 3 patients that we saw when I was in Boston, and we reported XCL3 deficiency, and at the same time, actually 2 other groups reported this condition. And again, just to show some of these, cranial fissures are similar to the patient that Jasmine presented, but also you see here the platyspondyly, the increased intervertebral space, the kyphoscoliosis. These are the hip abnormalities that I mentioned, and also short and plump metacarpals and short phalanges are also frequently seen. So mutations in this gene are actually scattered across the various domains. There are 2 very important domains functionally in EXCL3. One is the exocysteine domain, the other is a glycotransferase, because actually EXCL3 is a glycotransferase. And again, the variants indicated in blue here are the ones that have been reported in more individuals, in multiple individuals, and the other ones that have been reported in a single individual in each case. So what does EXCL3 do? So you have a core protein, which is serine residue, and then when you need to synthesize either heparan sulfates or chondroitin sulfates, the first things that happen is that you attach xylose and then galactose and eventually glucuronic acid residues to the serine of the core protein. And there are transferases, xylotransferase, galactose transferase 1 or 2, and eventually glucuronic acid transferase 1 that attach these 4 residues basically to the serine. And this is actually where EXCL3 now intervenes, and EXCL2 may also do this. So these are actually N-acetyl glucosyl transferases that attach an N-acetyl glucosamine residue to the glucuronic acid. And from now on, 2 other enzymes, EXT1 and EXT2, keep attaching glucuronic acid and N-acetyl glucosamine residues so that basically you have elongation of the chain. Now, at this point, you have various sulfotransferases that may modify the chains of the heparan sulfate and attach various sulfate residues to that. So here again, you have the core protein. You have the four residues that I mentioned before, the xylose, the galactose, the glucuronic acid, and acetylglucosamine. So the way you have to think of this is that the same protein may actually have multiple chains that are attached to it. And so you have first the XCL3 and then again elongation through XT1 and XT2. But if you have a mutated XCL3, remember XCL2 can also do this activity, but to a lower efficiency. Then you have fewer residues of N-acetylglucosamine that are attached to the four core residues, the xylose, the galactose, and the glucuronic acid. And at this point, XT1 and XT2 have more capacity to elongate the chain. So you have longer chains, basically, of heparan sulfate, but overall fewer chains attached to the same core protein. So where do we find heparan sulfates? Where heparan sulfates can be attached to transmembrane proteins, like in the case of Syndecan. This is very important, of course, for plasma cell function. They may also attach to GPI anchored proteins, like in the case of Glypican, or they may attach to soluble proteins, as in the case of Perlecan. What they do, they actually modulate the activity of morphogenetic molecules. So imagine to have a series of cells, and here you have the heparan sulfate, which is more abundant on this cell than on this cell. And by doing higher levels of heparan sulfate attached to these cells, they can attach here and attract basically some morphogenetic proteins. So they create a gradient of these molecules from this cell to this cell. So this is very important in terms of the effects at a cellular level. So you can imagine receptor engagement would be much stronger here than here. You have a role of heparan sulfate for ligand internalization, as shown here. And again, the more you have, the more likely it is that the ligand will be internalized. But it may also shield from proteolytic cleavage, and this is especially important for soluble proteins that have heparan sulfate chains attached to them. So at the cell biology level, they intervene in a variety of processes, including cell activation and proliferation, cell differentiation, cell migration, and cell adhesion. At the organism level, and this is obvious from the phenotype that just been presented in the case, they're extremely important in morphogenesis, but also in tissue homeostasis and repair. So indeed, when we discovered XCL3 deficiency in humans, it was not the first evidence that XCL3 was important for organ function, organ development, because there was, in fact, an animal model, a zebrafish, of XCL3 deficiency. XCL3 deficiency, this is called the boxfish. And this boxfish indeed has almost all of the features that we see in the patient. So there are cartilage, skeletal, and neuronal abnormalities. And you can see here, this is the box mutant. You can see that basically the pectoral fin is markedly shorter than what you see in a normal zebrafish. And that makes actually this fish unable to survive, to look for food and survive. So they die shortly after birth. They also have impaired jaw formation. They're unable to swim also because they lack actually swim bladder. And then they have also defective access sorting. So as a result of that, actually, they, like I said, they have very, very early lethality. But at that point, it was unclear whether also the zebrafish would have an immune phenotype. So we looked into this. And to do that, actually, we used basically analyzed for the presence of the thymus by crossing this boxfish with RAG2 GFP. And so, of course, the RAG actually, because it's a GFP targeted also, it would highlight very nicely the thymus in the wild type zebrafish as shown here. And you see that the box or XCL3 mutant has a much smaller thymus. So indeed, there is a problem in the thymus volume, which doesn't tell you, though, whether the problem is in the morphogenesis of the thymus or whether the problem is in a capacity to make T cells in the thymus because of a hematopoietic intrinsication. We also were able to rescue this phenotype by injecting the box fish with human EXCL3 mRNA. and that actually rescues completely the volume of the thymus and also the length of the pectoral fin. So it rescues entirely the phenotype of the zebrafish. So with that in mind, I will leave to Marita to discuss actually at this point what is or what are the potential mechanisms of the T-cell defects, which is essential also to the question that just been posed. Do these patients benefit potentially from a bone marrow transplant, or do they benefit from a thymus transplantation? And there are several hypotheses that can be considered. One could consider, because of the role of EXCL3 in, again, in attracting morphogens and modulating the activity of morphogens, there could be a reduced generation or perhaps migration, impaired migration or expansion of early hematopoietic and lymphoid progenitors. That would call for a hematopoietic intrinsic role of EXCL3. There could be even a defective intrathymic T lymphocyte differentiation itself. Or finally, there could be a role in thymus development as the presence of multiple organ abnormalities in the patients as well as in the animal model might also suggest. And with that, I leave it to Marita at this point to discuss these options.
Thank you, Gigi. Thank you, everyone, for inviting me. And just let me share my presentation. I'm just gonna continue from where Gigi basically left, and just explain what kind of assays we could use to try and answer these three questions. So for the first questions, the reduced generation, migration, or the expansion of the early progenitors, hematopoietic and lymphoid progenitors, we can use induced pluripotent stem cells generated from fibroblasts of patients with the XL3 mutation, and then differentiate those through the embryo bodies, intermediate step to CD34 positive cells. And when we did that in the past for the patients that Gigi just described, what we could see is that indeed there was a defect in the number of CD34 cells that could be generated in the IPS from the patients compared to the control cells, and in the number of the cells expanded in culture. So definitely this was one of the issues, that intrinsic generation of the hematopoietic progenitors is altered in these patients. The second question that Gigi posed is there also an altered thymus development in terms of the thymic tissue? And how we can test this is by using this assay, again, starting from induced pluripotent stem cells, so the patients with the XL3 deficiency. We can differentiate them through a couple of intermediate steps to thymic epithelial progenitor cells. And the intermediate steps are the definitive endoderm and ventral pharyngeal endoderm by using this series of growth factors that need to be given to in culture at timing, at the correct timing, and with the correct amount during the 2 weeks of culture. And then we can follow the differentiation of these cells from IPS to thymic epithelial progenitors by looking by qPCR or by bulk RNA sequencing at markers that are expressed at the different stages. And for example, SOX17 is a very good marker for the definitive endoderm stage, and then regulates afterwards, while OXA3, EYA1, FOXN1, and cytokeratin 5 are markers that are starting to be upregulated at the VP stage, and then further expressed at the higher level at the thymic epithelial progenitor stage. And when we compared the IPS, the TEP generation from IPS of patients with the XL3 deficiency to control, what we could see is that actually the patient had a higher expression of SOX17 and a decreased expression of the TEP markers EYA1, FOXN1, and cytokeratin 5 to indicate that these cells might be stuck at a more intermediate progenitor stage, something in between the definitive endoderm and the thymic epithelial progenitors, so indicating that there might be a role in the XL3 in the generation of the thymic epithelium, and then thus the stroma of the thymic tissue. So finally, the last question is there also an intrathymic T lymphocyte differentiation? And to answer this question, we use the assay that was shown earlier by Jasmine, the artificial thymic organoids. This is an assay that we have been using in the lab, and I think maybe some in the audience know what we are doing and sent us samples for this assay. And this is a very powerful technique that was developed in 2017 by Guy Crooks and Amelie Montelhagen in their lab, and it's basically the organoids are made by aggregating CD34 positive cells isolated from the bone marrow, cord blood, mobilized peripheral blood, but also unmobilized peripheral blood, and they are aggregated with a murine stromal cell line called MS5 that they engineer to express the human Notch ligand DLL4, which is sufficient to induce T cell T cell lineage commitment in these cells. Once the cells are aggregated, we make a cell pellet and then resuspend these cells in a drop that then is plated on a filter floating on a well where there is a media that is made by RPMI, B27 supplement, IL-7, FLT3 ligand, stem cell factor when we have CD34 cells from peripheral blood and ascorbic acid. And then we culture and change the media twice a week. We culture the cells for 6 to 12 weeks, but already at 6-7 weeks, we can see a differentiation. And what we see is something similar to what was shown earlier by Yasmin, and we can follow the differentiation of starting from the CD34 positive cells through all the stages, the early and the late stages of the cell differentiation, starting from the ETP, which are CD34 positive and negative for CD5, CD7, and CD1A. And then these cells start to acquire CD5 and CD7, the earliest markers of T cell commitment. Then they downregulate both CD5 and CD7 and upregulate CD1A. And at this point, when they are at this stage of CD1A high, CD7 low, it's a stage in which they become double positive and they express CD4 and CD8. And then the final differentiation, they also rearrange the TCR receptor and they become CD3 positive and TCR alpha beta positive. A majority of the cells in the ATOs though remain double positive, so they don't fully mature, but this assay is definitely very useful to study in particular early defects of T cell differentiation. And as I mentioned, in the past 7 years, we have been using this assay in several patients, and so far, I think our cohort of patients is more than 270 patients studied so far, and we have been studying all kinds of defects. We characterize defects in patients in which the genetic defect was already characterized, and we had an idea of where the block in development could be for mouse models that were present or other studies done in other patients. But we also characterized novel genetic defects, for example, pre-TCR alpha patients with characterized using the ATO system, and we could reproduce what was seen in the patients in which there are not TCR alpha beta positive, but they maintain TCR gamma delta positive cells. We also can see that in some patients, there is no defect in the differentiation. And these are patients in which either there is an enzymatic defect, for example, ADA or PNP. And this is due to the fact, not because the patients don't have an intrinsic developmental defect to T cells in these diseases, but because the MS5 are actually producing these enzymes and cross-correct the defect in the culture in the ATO and allow the TZ34 cells to become T cells. The majority of the other patients in which we didn't find defect are instead patients that have a defect not intrinsic to the CD34 positive cells, but due to the thymic stromal defects. And among these, some of them are very well-known thymic defect, the George syndrome, Church syndrome, CHD7 mutant patients, but we also characterize novel mutations, for example, OXA3, which is still unpublished, and other genes, other more rare defects like TP63 and TBX1. So as I mentioned before, the results were shown already by Yasmin, and what we saw in the patient in this case that we didn't really see a defect in differentiation. As she mentioned, in this case, the control wasn't one of the best controls, but in we could see production of T cells, and in a similar way that we could see it in the patient. Actually, when we look at the absolute count, they were even more cells in the patient than in the control. So this led us to conclude that the answers to these three questions that we posed before is that we think that there is a reduced generation, migration, expansion of the early hematopoietic progenitors in these patients. There might be a component of altered thymus development, but what we didn't see was a defective intrathymic T lymphocyte differentiation. We have to say that even though we love the ATO assays and we use it as much as possible, the ATOs still have some limitations. And the limitations are that indeed in the ATOs we cannot detect a migration defect, so migration that can be between the bone marrow to the thymus or intrathymically. And also we cannot account for the reduced generation of the hematopoietic progenitors because we plate a fixed number of CD34 cells, and so we cannot make up this difference. But what we could do in the ATO based on some, and this is just kind of a bit of like something interesting that we just found out in these patients, and then we can see if someone has an idea of what is going on in these patients. So we wanted to test whether if we could expand the CD34 cells in the ATOs, can we improve the differentiation, the T cell differentiation in these patients? And we did some studies recently, and we found out that we can adding TSLP to the ATO culture for 3 weeks, we can expand specifically CD34 positive cells. So we thought also, what can we see? Maybe if we expanded the CD34 cells with TSLP in XL3 mutant patient, we can see an improvement in T cell differentiation. And we tested this in the same patient that was sent to us by CHOP, and what we could see is that in the control, when we add TSLP, we don't really see much of a difference in T cell differentiation. It was very similar. But when we add the TSLP in the EXL3 patient, we could see an improvement in the production of double positive cells and also in the production of TCR alpha beta CD3 positive cells. And this was true not only in frequency, but also in absolute count. And we can see that the absolute count in total cells in the ATOs, but specifically in the more mature CD4, CD8 beta positive cells and TCR alpha beta CD3 positive cells, we could see a consistent increase in absolute count. So we were really curious to see whether that was something that happened only in this patient. So we asked another collaborator to send us blood from a patient with EXL3 mutation. So we tested the same theory again, and then we can see that also in these patients, if you look at the regular culture that we use for the ATOs, there is really not a big difference in the production of the CD4, CD8 double positive cells and TCR alpha beta positive cells between control and patient. But when we add the TSLP, again, the control doesn't change very much, but the EXL3 patient and an increase again in double positive cells and TCR alpha beta positive cells, both in terms of frequency, but even more importantly in terms of absolute counts in the total cells and in the double positive and TCR alpha beta positive CD3 cells. We don't know what the mechanism is here, but we think that this may be something that can be indicating that in these patients, we can find a way to expand the CD34 progenitors that can be a way to improve their T cell development. But this is just what we are at this point, and I think I now can stop sharing and we can go back.
Thank you both so much. I certainly learned a lot. And that is so interesting. I wonder what we can discuss in the chat / amongst ourselves what we think we could do about that. But we thought we could then, now that we've learned a lot about the condition, just talk a bit about how we ended up treating our patient. Jasmine, if you want to go ahead and update us.
Yeah, thank you both so much. That was very helpful. So for our patient and how she's doing now, she actually underwent fully matched paternal bone marrow transplant with no conditioning at just under 4 months of age. She had no signs of Omenn syndrome prior to transplant, and she was treated with MMF post BMT for GVHD prophylaxis, and that was stopped 2 months later. Currently, she is about 6 months post bone marrow transplant, and she has donor T cell engraftment at 91%, which is great. And her T cells and B cells are recovering. CD3 positive total T cells are 384, but predominantly memory phenotype. And she's clinically doing really well.
I guess her B cells were always there, but now there's the function is starting to slowly come back. She's still on immunoglobulin replacement, but she is doing pretty well.
Can I ask what's the neurological evolution of the case?
She is, I haven't seen her in a little bit, but she's doing PT, and I was just reading some of the rehab medicine notes, and it sounds like she is doing a little bit of interacting with toys and bringing her hands to center, but I still think she has a lot of neurologic deficit. Yeah. We didn't go through all of her congenital anomalies, but she has a significantly abnormal brain MRI, and she also does have the spinal, like the axial instability a bit. So she did get craniosynostosis surgery, and so her head looks a little different than the CT that I showed, or that Jasmine showed. But and she has the exact limb abnormalities as well.
Yeah, so typical case. So Terry is asking a question, do the assay expanded cells have normal mitogen function? And I think, Marita, I don't think we tested mitogen function in this patient, but in other cases, yes, the T cells that develop in the ATO assay, they do have proliferation capacity. And they also develop a pretty polyclonal repertoire of T cells. Again, we didn't test repertoire, and I don't know about the repertoire that of the T cells that develop in the ATO assay for the XCL3 deficiency. It would be interesting to do that. We haven't done it, so I can't say anything.
That would be interesting to know.
That's for you. That's for you.
Yeah. So John Barber asked, does the predominant memory phenotype in her T cells at this point concern us that her reconstitution does not represent true de novo T development? I think that it is possible that her unconditioned transplant that she received from her father could be, at least the numbers we see now, could mostly represent peripheral expansion of more memory T cell phenotype. I think our transplant team was hesitant to use conditioning with the rest of her anomalies. She has multicystic kidney. I don't think that she has, to my knowledge, I don't know that she has renal cysts.
No.
But yeah, at least, yeah, I don't think she does. But I do think that is probably what it is.
And Utrex?
Oh, that's a good question. We do have PCR spectrotyping that's still pending because we had just sent it. If we give myself a minute, I will look, but I actually didn't click on her Trex. She has pretty low naive T cells, so I am not hopeful that her Trex are very high. She has low Trex, but 2218 per 10 to the 6 CD3 cells. So present but low.
Antibodies?
She does actually. I mean, she has her IgM is like 26, and she has normal IgA, and she's on subcutaneous immunoglobulin replacement still. She hasn't had. I feel like though the immunodeficiency part was a quite severe part of her phenotype, she hasn't, luckily, knock on wood, hasn't had infection, really many ramifications from having SCID.
If I may make a suggestion, I think
Please.
Whitney, Jasmine, I mean, you have proposed a case here. I think it would be important to touch base with the other groups that have reported these cases and provide a summary of the outcome of these patients, including the outcome of stem cell transplant. Because yes, 3 out of 3 were alive after the transplant, all of them actually with engraftment, but the questions that were asked actually are good questions. I mean, how good is the T cell reconstitution following transplantation? I think it remains to be fully addressed.
Absolutely.
I totally agree. I
And then
think
Jessica is also another important question, I think.
Jessica asked, have any of the patients received hematopoietic stem cell transplant had complications that suggest a substantial primary thymic defect?
Well, Jessica, if I may say there, I mean, first of all, what would be, you could argue that Omen syndrome that was seen in some of those patients and actually has been seen also in the OXA3 deficient patient that Marita was mentioning, which is still unpublished. That might also result from a primary thymic defect. In that case, you do not support fully normal thymopoiesis, and you may generate a few clones of T cells that expand and eventually create an Omen phenotype. But otherwise, it's difficult to say. I would simply say that when you see many organs involved, and especially craniofacial abnormalities, it's easier to think of a thymic defect, especially if there is also heart involvement. I mean, all of these are present in the XL3 deficiency. So that makes the issue of bone marrow transplant versus thymic transplant complicated to start with. But I think the data would suggest that stem cell transplant is the way to go.
And
Right.
then
So, okay, so that's a very important information. So the one patient that I mentioned was still pending. See, this is why it's important to report these cases. Still no immune reconstitution. The only thing I would say about the thymic tissue implantation, it would be important to biopsy the thymus tissue that's been implanted, because actually in the XL3 case, that patient required two interventions. No immune recovery after the first thymus tissue implantation, normal T cell development after the second one. So sometimes one has to look at exactly what happens. Central, yeah, severity. So do you have any evidence of GVH in your case?
no, she was on MMF for 2 months, but now she's off immune modulation and she doesn't have evidence of GVHD.
And likewise, the other 3 cases that I'm aware of, none of them had evidence of GVH.
And then Alexis Katz asked, does she have any of the neurologic manifestations or behavioral problems that can be seen in Hurler or Hunter syndromes, given that both of these and EXTL3 deficiency involve abnormal heparan sulfate metabolism? That's a good question. She is still so young, like she's only 8 months old, but she really is a pleasant little gal, and it is sort of really doesn't have is pretty developmentally delayed. So I don't think we have a great picture of what her behavioral future will be.
But again, I agree with that. I mean, I agree with Alexis. It's a great question. One more reason why a follow-up, I mean, what happens in the life of these individuals, those that survive, what are the features later in life? I think it's important to assess that. So I think a review on these diseases is needed at this point.
Completely agree. And then, is there 2 patients who have undergone thymic implantation, or is this the same patient we're talking about?
It's the same patient.
Okay.
Yes, it's the same patient.
So there was another patient or the patient at WashU who underwent, and then 18 months later still doesn't have immune reconstitution. Okay. It's interesting. I mean, yeah, exactly like everyone's asking, you worry if even with the stem cell transplant, there still is a thymic defect present. You just worry about the longevity of their immune reconstitution, even though we see T cells present. How long can those predominantly, peripherally expanding memory phenotype T cells hang on? Any other questions?
Looks like this is it.
I think that was it. But thank you so much for all of the great learning today, and just a reminder, and thank you to Jasmine for a great case presentation. But I totally agree that I think we should all collaborate to write a review of these cases, because they're rare now, but they won't always be rare, and it is helpful to know how to treat them in the future. So join us on a monthly basis from now till next summer for more of these great webinars. The next one is on October 7th. So look out for those emails to get registered and get it on your calendars. And if there are young trainees in the listening audience, if you have interesting cases that you think could be good to present at one of these webinars, reach out to one of us, since my name is here, or someone in the Early Career Immunologist Committee, and we will help you get connected.
Thank you all.
Thank you.
Thank
Bye.
you.
Thank you, everyone.
Thank you guys. It was great. Have a good night.
Thank you, Gigi.
Bye.
Thank you, Marita.
Thanks.
Bye-bye.
Thank you.
Bye-bye.